All right, good afternoon, everyone, and welcome to the Immune Deficiency Foundation's SCID Compass Lunch and Learn. Today, we will hear an update from our program partners at the Association of Public Health Laboratories. My name is Emma Martins, and I'm the Program Manager of Community Health at IDF. On behalf of the Foundation, I'd like to thank you for joining us today for this program. We are excited to host this event for the IDF community. IDF is dedicated to fostering a community empowered by education. We want you to remember that IDF is committed to our community, serving you as a trusted resource through technology and innovation. We are here to give you the tools and information to become empowered and offer you our compassion, understanding, and support to emphasize that you are not alone on your journey. Today's program is part of IDF's regular series of bite-sized programming that will provide diagnosis-specific information and support to our community wherever they may be. Before we begin, I would like to point out a few housekeeping items to keep in mind for the webinar. This afternoon, we are using the Zoom webinar feature. Attendees should be able to see the slides and our presenters and be able to hear myself and our presenters speak. Attendees will not be able to activate their video camera or their microphone. There will be the opportunity for questions after the presentation. You are welcome to submit any questions you have for our presenters as you think of them throughout the session. Please type them in the Q&A box in the control panel on your screen. Please do not include any personal health information, as all questions will be anonymous and read aloud. A brief disclaimer. Please remember, the information presented during this event is not intended to be a substitute for medical advice, diagnosis, or treatment. We are here today as a trusted source and friend to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational event. The SCID Compass program is supported by our partners at Chiesi Global Rare Diseases. We are so grateful for their ongoing support. SCID Compass, an educational program of the Immune Deficiency Foundation, was created in 2018 with the purpose of guiding parents, families, and the medical community through the journey of learning about this rare, life-threatening medical disorder and find support to navigate the health challenges along the way. All of our SCID Compass resources can be found by visiting www.scidcompass.org. The website offers a robust variety of free online and printable materials for anyone eager to learn more about this condition or share information with others. Topics cover every step in a family SCID journey, from newborn screening to returning home after treatment and everything in between. You can view our website in Spanish, French, German, Portuguese, and Tagalog by clicking on Select a Language in the upper navigation. We also want to highlight our SCID Compass Toolkit, a downloadable summary of the website that you can order and print in 12 different languages. And now I am so pleased to introduce our presenters for today. Ruthanne Scheller manages the New Steps program at APHL, and Amy Gaviglio is a genetics and public health consultant for newborn screening and genetics at APHL. Both were integral to the planning and implementation of the SCID Compass program and resources, and we are so excited to hear an update on their incredible work, which continues to benefit the SCID community. Welcome, Ruthanne and Amy.
Thanks so much, Emma.
All right, just give me one sec while I pull up your slides. All right, take it away, ladies.
Awesome, there we go. And Emma, I think at least from my side, it's still showing up. There we go, perfect. So hi everyone, many thanks to our friends at the Immune Deficiency Foundation for inviting us to present today. I'm honored to be presenting with my colleague, Amy Gaviglio, on behalf of the Association of Public Health Laboratories and our SCID Quality Improvement Project team. Thank you all so much for tuning in. Next slide, please. So today I'll begin with a brief background on newborn screening for SCID. I'll share a little bit about where we are with screening today and some lessons that we've learned along the way. And then I'll be handing it over to Amy to share some background behind our SCID screening for premature infants project and some updates on where we are with our analysis. If you're interested in taking a closer look at the SCID newborn screening process, I encourage you to check out our other recorded SCID Compass webinar that's archived on the SCID Compass website. Next slide, please. All right, so let's start with a brief background on newborn screening for SCID. Next slide. Okay. So when we think about newborn screening, we often think about the testing or the analytical piece, but it's really important to recognize that newborn screening is a process, not just a test. There are pre-analytical or pre-testing and post-analytical or post-testing pieces, as well, of course, education and communication components that all have a major role in ensuring that the newborn screening process goes as smoothly and efficiently as possible. It's also important to note that when we're talking about newborn screening, we differentiate it from a diagnostic test. Newborn screening is a risk assessment, which means newborn screening is looking at the newborns that are at an elevated risk of having a disorder. Next slide, please. So on this slide, you'll see a picture of the newborn screening dried blood spot card. This is a sample from Wisconsin. This piece of paper is what's used to collect the blood from newborns that's then sent to newborn screening laboratories. It's really remarkable to think about all of the disorders that every baby is screened for using these 5 circles and all the thousands of blood spot cards that are processed every day of the year by newborn screening laboratories. The information that's collected on these blood spot cards helps laboratories interpret as well as report out results. Next slide, please. So this visual gives you a closer look at how newborn screening works. Newborn screening is performed to a seemingly healthy population with approximately 4 million babies getting a newborn screen done each year. Newborn screening programs use dried blood spot cards, like the one that was on the previous slide, to filter out the babies that are at higher risk of a disorder. So those that are pictured at the top of this diagram. While those who are at lower risk, so those at the lower bottom of this diagram, pass through. Those at higher risk, back at the top, are referred to diagnostic testing, which can then determine if they do in fact have the disorder, and these cases would be referred to as a true positive, versus if they are not actually affected, which we would be considering a false positive. Since newborn screening doesn't want to miss someone at high risk who potentially may have the disorder, newborn screening laboratories will cast a wide net, and that's where these false positive cases come in. Now back down to the bottom of this visual, for the babies that do pass through the screen, it's important to remember that newborn screening is a screen. And while newborn screening programs strive to not miss any cases, there are some cases where a newborn may be affected and may have been missed by the screen. And that's where these false negative cases come in. Next slide, please. So on this slide, I'd like to highlight 4 key points that are important for us to keep in mind when we think about newborn screening. The first, newborn screening programs are public health programs. So they find themselves balancing considerations for the population as a whole, as well as individuals. Newborn screening programs rely on timely coordination between numerous partners, including couriers, birthing centers, primary care providers, and clinical specialists, to ensure that best possible outcomes are achieved. Second, newborn screening programs are state-based, and you'll see differences from one newborn screening program to another. And Amy will be touching on some of these differences in just a moment. Third, newborn screening programs are also opt-out programs. So since newborn screening is considered low risk with major benefit, newborn screening is performed by default, and parents must opt out if they wish for their newborn to not be screened. And the last key point is newborn screening programs are designed to detect treatable, and I really want to emphasize treatable conditions. Disorders are only added to state newborn screening panels if they meet certain criteria, including having a treatment available. Next slide, please. So here's a beautiful visual of the wide array of partners that all play a role in ensuring newborn screening is a success, from families, policymakers, public health decision makers, primary care providers, birthing centers, public health programs, clinical specialists, couriers. Those are just to name a few. They all play an instrumental role in the newborn screening system. Next slide, please. So how is newborn screening for SCID accomplished? Newborn screening for SCID is done by looking for T-cell acceptor excision circles, or TREX for short. TREX are found when T-cells are being produced. Since babies with SCID have few to no T-cells, they also have few to no TREX in their blood. SCID is the first ever newborn screening disorder to use DNA for first-tier testing, which is already proven to pave the way for other disorders such as spinal muscular atrophy, also known as SMA. Next slide, please. So it's exciting to share some new and upcoming testing strategies. Check analysis alone has shown to miss later onset ADA SCID cases. The addition of examining ADA enzyme activity as part of an FDA-approved non-derivatized testing kit may provide a better and more reliable method for detecting ADA SCID. And while the relevance, diagnostic, and prognostic value of PREC analysis in newborn screening is still being debated, some programs have explored multiplexing it with TREC so that they can also detect B-cell deficiencies. Additionally, some newborn screening programs in the United States have started exploring adding multi-gene SCID panel as a second tier for newborn screening, which could allow for more information about phenotypes, earlier detection, and treatment. Next slide, please. So now that it's been approximately 15 years since the first 2 states started screening for SCID, and 5 years since all states have been screening for SCID, where are we with screening? Next slide, please. So I'd like to start with a path to SCID newborn screening in the United States. Newborn screening for SCID began back in 2008. Wisconsin and Massachusetts were the earliest adopters of SCID newborn screening, offering screening even prior to when SCID was added to the recommended uniform screening panel in 2010. Following the addition of SCID to the national recommended panel, California and New York implemented SCID newborn screening, as well as the Navajo Nation and Arizona. As time progressed, additional states began to onboard SCID newborn screening. And in 2014, APHL was awarded our first SCID cooperative agreement, allowing us to provide financial support to 11 states to help them with onboarding SCID. At this time, a little less than half of the states were offering SCID screening. In 2015, more than half of states were offering universal SCID screening. And then by 2016, more than 75% of newborns were screened for SCID. By 2017, 94% of newborns were screened for SCID. And then by the end of 2018, a full 10 years later, all 53 newborn screening programs offered SCID newborn screening. Next slide, please. So you're probably wondering, why did implementation take so long? As I mentioned before, newborn screening programs are state-based. Each state's unique legislation, advisory committees, advocacy groups, fees, equipment, and personnel all play a role in the onboarding of a disorder. Many barriers to adding SCID were similar to those faced when adding other disorders to state panels, including obtaining state legislative mandates, acquiring fee increases to support SCID newborn screening implementation, validating testing, developing follow-up protocols, creating educational materials, and hiring staff. But why even longer for SCID? A recent analysis noted that it took on average 4.3 years to implement SCID after it was added to the recommended uniform screening panel, longer than the other 5 disorders displayed in this graph that were also added to the recommended uniform screening panel around that same time frame, which was between 2010 and 2018. SCID was the first disorder screened to utilize molecular technology as a first-tier screening test. Acquiring this new instrumentation posed several challenges for newborn screening programs, including finding funding to support purchasing new equipment, training staff to perform this testing, and securing or adapting adequate laboratory space for the equipment. Additionally, there were new challenges presented while interpreting these molecular results for follow-up. And this was a whole new realm for immunologists who were not previously engaged in the newborn screening arena. When screening, we also discovered a need for modified screening algorithms, which may be particularly helpful for screening preterm infants. And I'm excited for Amy to elaborate on this just a bit when we talk about background behind our project. But it's also important to point out that even with all of these unique challenges, the addition of SCID presented newborn screening programs with opportunities for growth and collaboration. And it's really set a model for other disorders and has been a great example of how newborn screening programs can support one another and share best practices. Next slide, please. So on this next slide, we can take a look at some things that we've learned thus far. Overall, birth prevalence is higher than we previously thought. So we used to think it was around 1 out of 100,000. We're now recognizing it's closer to 1 in 58,000. We're also seeing higher numbers in certain populations, as well as such as the Navajo Nation and the Somali populations. After years of screening, we've also discovered that there's a disproportionately high number of screen positives in the premature and low birth weight population, which has really led to the inception of our project that Amy will be talking about. And then screenings also revealed that we are missing some milder or later onset phenotypes still with TREX. So there still needs to be clinical vigilance. And despite newborn screening, we're still seeing higher than desired rates of infection related to morbidity and mortality. And this is likely due to post-analytical practices and not following appropriate guidelines. The Primary Immunodeficiency Treatment Consortium put together this graph that you see here on the right. When we look at how individuals with SCID are identified, we now see much more diagnosis through newborn screening over family history and clinical presentation, which is really good and expected, and it provides us with opportunities for early treatment. I'll now be handing it over to my colleague to share some background and updates about our SCID project and share some updates about harmonization efforts as well. Thank you.
All right, thank you so much, Ruthanne, for setting up the remainder of our talk so nicely. So as Ruthanne mentioned on the last slide, one of our really key learnings from our experience in newborn screening is how difficult it has been for us as a newborn screening community to provide efficient and effective screening for SCID in the premature low birth weight population, which very much led us to our study. So next slide. But before I really dive into the study in more detail, I kind of want to further explore some of the lessons learned from SCID newborn screening and highlight a SWOT analysis that was recently done by a group of experts during the revision of the newest Clinical and Laboratory Standards Institute, or CLSI, guideline on newborn screening for SCID and T-cell lymphopenias, which will hopefully be published in the next few months or so. And Ruthanne touched nicely on many of these, but I think it's nice to have everything in kind of one nice, neat graphic to show both our successes and opportunities. So what we know so far as we think about TREC-based newborn screening for SCID is that, obviously, as Ruthanne mentioned, this does enable early diagnosis and treatment pre-symptomatically. It has been successful in identifying individuals who are at risk for SCID because TRECs are certainly an excellent surrogate biomarker for this disease. In terms of some weaknesses that we've identified, so there still remains really no consensus on overall interpretation of results and follow-up actions needed. And this speaks a bit to the variations among programs, but there just remains quite different practices across the board, and we will touch on that a little bit later as well. We've talked about the issues in trying to screen the premature infant population. And we've also realized that there is kind of questions around urgency and some concerns that, especially for those infants who really have no TREC results, where we're really concerned about the risk for SCID, whether or not they're being notified and treated urgently enough. And so we do have opportunities. Ruthanne has mentioned this already in terms of ongoing improvements in our testing modality, our ability to multiplex TREX with other biomarkers, including those that enhance our screening for T-cell lymphopenias or B-cell lymphopenias, but also kind of unrelated diseases like SMA. And there is really, I think, an opportunity here as well to start using our lessons learned in the 10 plus years we've been screening and starting to build some consensus among both the clinical and laboratory side of things, as well as the public health side of things in terms of best practices around screening. In terms of threats, Ruthanne mentioned that unfortunately we still do see infection-based morbidity, even with newborn screening, and this may speak again to getting the importance of consensus and follow-up as well. This lack of harmonization and uniformity is difficult both in terms of practice, but we'll speak to this as well. It's been difficult in terms of doing multi-center studies as well. So let's move on to the next slide. So the difficulty in applying newborn screening to the premature low birth weight population is not in any way limited to SCID. In fact, we truly struggle across many of our screen diseases in this group, in this population. And so this led to the Clinical and Laboratory Standards Institute, which I've mentioned before, also referred to as CLSI, to develop guidelines specifically for newborn screening in this population. You can see a screenshot of that document here. So these guidelines suggest that newborn screening programs utilize what we consider kind of a serial screening protocol for these babies. So here we see a specimen collected at kind of our usual time of 24 to 48 hours after birth or before the administration of any blood products. And then we ask for another one around 14 days of age, and yet another or third specimen around 28 to 30 days of age, so long as the newborn is still inpatient. And the reasoning behind the use of serial screening protocols is to try to mitigate this disproportionately higher number of out-of-range results that we see in general in newborn screening, owing to things like just immature physiology at that point in time for these small newborns, or secondary confounding factors like surgeries or other treatments and interventions. And so what this ends up meaning is that despite the relatively large number of positive results that we see in this population, again, for both SCID and for other diseases, the vast majority of these newborns actually do not have our target screening diseases. So the thought is, by simply kind of applying a routine serial screening protocol, we can both reduce unnecessary diagnostic testing. We're just going to ask for some repeat newborn screens, so we can ultimately get a better look at the baby's actual physiology as it grows and matures. It is important to note, though, that not all states utilize a protocol such as this. So this is another one of those state-by-state variations. And to point out, for the purpose of SCID, this protocol, and this is kind of what we've started to see in our research, isn't always actually enough to achieve resolution of out-of-range TREC results, especially in those very, very premature newborns. And I'll highlight this a little bit later as well. Next slide, please. So what is it about TREC analysis in particular that causes us such issues in the premature population? It really comes down, it seems, to two main considerations. So the first is that relative immaturity of a premature infant's immune system and their maturation of T cells. Additionally, while TRECs are, as I've mentioned, really an excellent biomarker for thymic function, it is not a specific biomarker to SCID. So we're really picking up anything that may affect that T cell maturation. So when we see positive screens, they may represent other conditions like 22q, congenital heart disease, leukemia, other metabolic defects. And so certainly these are conditions that we see more in premature and low birth weight sick newborns. And so that is really part of the confounding factor that we're dealing with. Next slide, please. So this all brings us to our study, which sought to evaluate the characteristics and outcomes of SCID screening in the premature population using data aggregated across multiple state programs. And the ultimate intention of the work is to utilize this aggregated data to develop potential strategies for reducing unnecessary diagnostic testing, unnecessary repeat screening, or unnecessary other follow-up activities in this group, while also ensuring that any affected babies are still getting timely diagnosis and treatment. Next slide, please. So to achieve that kind of ultimate goal, we had 3 specific aims in our study. So the first was to assess how often there were screen positive results in this population and their associated actions across distinct gestational age or birth weight categories. And the second aim was to look at outcomes of screen positive results in this population, again, particularly focusing on those false positive rates. So how often we're seeing positive results in infants who end up truly being unaffected or not having either true SCID or an associated T-cell lymphopenia. And again, we wanted to look at this across various gestational age or birth weight groupings. And finally, the last specific aim was then to kind of take what we learned from specific aim 1 and 2 to identify potential recommendations that can reduce either the false positive rate or the follow-up activities recommended for this population. Next slide, please. So for this project, we had the participation of 7 states. And between those 7 states, this represents about 27% of the birth population in the US, or a bit over 1 million births. So we felt pretty good about our coverage here and our ability then to generalize some of our findings nicely across the nation. Next slide, please. So while combining data across just 7 programs may seem easy, it is and was surprisingly difficult because of these wide variations in practices across newborn screening programs in the US. And there are so many variations that I think we often say right now that if you've seen one newborn screening program, you've seen one newborn screening program. And variations in practices span truly, you know, the newborn screening system, and especially both laboratory and follow-up practices. So we have some states who requested 2 routine screens for newborn screening. So they get their normal screen at 24 to 48 hours, and then request a second screen at 7 to 14 days of life. So that in and of itself can be a variation between states. We've talked a lot about the premature and low birth weight screening protocols, so whether or not those are utilized or recommended by the program can differ. How they're testing for SCID can differ, as well as how the test results are actually reported, and I'll talk a little bit about this again later on. If we look more in the follow-up, what is recommended for follow-up after screening? Are they asking for a repeat newborn screen? Are they asking for diagnostic evaluation? That can differ. What they're calling the outcomes of their findings, their so-called case definitions that are used, can differ, and this can be really difficult then when we're trying to actually aggregate data, again, across programs and look at outcomes. And then, of course, the extent to which diagnostic data is collected to kind of support the ultimate outcome as well. So quite a few variations across programs that we were dealing with. Next slide, please. And so for the purpose of this project, we had, owing to this, several issues to overcome, again, due to these variations. So first, we had to really work with programs on their ability to link specimens to single individuals, which isn't always done or quite frankly easy to do. But we really wanted to make sure that we were looking at this from a patient perspective and not a specimen perspective. So making sure that we were always looking at how many specimens, were linked to a single patient, and the outcomes linked to a single patient was really important for the purpose of this study, but quite frankly was quite difficult for some programs. Additionally, programs measure and report results using various values or various units. So we have some programs who report their results by TREC copy numbers. So here they're actually looking at and trying to quantify the number of these TRECs that they see in the specimen. Other programs use what's called a CQ or CT value to report their results. And this is a value, it's essentially a measure of the number of cycles in the PCR reaction that Ruthanne mentioned in terms of how we do our screening. Essentially how many cycles it takes for the TREC values to reach a certain threshold. So if you have very low numbers of TRECs, you would expect your CQ or CT value to be very high. It would take many, many cycles to try to get to a certain threshold. We also have programs who report in a third way, a value known as a multiple of the median. And so this is a way that programs can essentially normalize the TRECs in the sample to the median TRECs seen in the population. So in addition to those reporting differences in terms of all these different types of values we were getting, what programs call their results also varied. And this can be surprisingly confusing when you're looking at various screening outcomes, as well as trying to kind of combine similar follow-up processes. So some programs use the terms positive, abnormal, borderline, inconclusive, pending. We really had to kind of do a dictionary for every program and then figure out the best way to combine kind of like results. And then finally, we had to try to combine and assess the various follow-up recommendations that programs use. And so this may include, again, just doing a routine repeat request. So if you are using this low birth weight protocol, you may say, okay, your first specimen was positive. We're just going to wait for that routine specimen that we already asked for at 14 days. Other programs may say, well, we're going to do an additional repeat request. We want another repeat, but we want it sooner or outside of our normal processes. Or you may be sending these children to full clinical or diagnostic evaluation, which usually included flow cytometry. So we had our work cut out for us, but I think we were able to do it. So next slide. So yeah, these next few slides will illustrate some of our preliminary data. And this slide shows what we, quite frankly, largely assumed and have seen anecdotally, and there have been some smaller reports in the literature about this as well, that TRECs increase with increasing gestational age. Again, this is not surprising. As the child's physiology matures, that includes their immune system and their thymic function, we would expect to see more and more TRECs, especially in those individuals who do not have a T-cell lymphopenia. So this idea here is shown on the left. So if we look at TREC copy numbers, again, as a function of the multiple of the median, with gestational age on the x-axis, we can see that the TREC values kind of start to normalize pretty much at around that 36-week gestational age. On the right is a similar graph, but looking at the CT values as a function of the moms. So that's why you see it going down. We would expect, lower CT values for higher TREC numbers, or as TREC is kind of getting more to that normal expected level. So again, we're seeing this idea that as an infant gets older, as they kind of increase in their corrected gestational age, we're going to start to see an increase in TREC values over time. Next slide, please. So this data illustrates the outcomes of screen positive results in the premature population, and specifically how often screen positive cases end up either being a true positive case. So in this scenario, we were considering a true positive case, either SCID or a T-cell lymphopenia, or versus a false positive result. And so we characterized false positive results as only those kids who went through clinical evaluation versus those who had a normal repeat newborn screen. And so we can see here, yeah, obviously the vast majority of our cases that had positive results for SCID, they ended up resolving on this normal repeat screen. Well, you can see, especially when comparing very premature babies, so those say in that 22 to 26 weeks gestational age, that we're really hovering maybe around 2% of cases actually being a true positive case, versus those, if we're looking at those who are kind of older and maybe less premature, so that 32 to 36 weeks gestational age, now we're starting to see somewhere around 6% true positive. And so, you know, what that really shows is how often early on our positive results are really truly likely due to this physiological immaturity of the premature infants. Next slide, please. So this graph kind of riffs on that last graph, and it shows that the prevalence of true positive outcomes rises steadily starting around week 32 gestational age, with a pretty steady increase from that point on. So again, what this means exactly is essentially it shows that positive results in premature infants that are nearer to term are more likely to reflect a true T-cell lymphopenia, whether that is SCID, leaky SCID, or a syndrome that's associated with T-cell lymphopenia, versus positive results in very premature infants, which are more likely to be the result of prematurity alone or other confounding factors or interferences. Next slide, please. So if we kind of flip the way we are looking at this graph a bit and consider the percentages of screens that ended up normalizing over time, we can see that by 36 weeks corrected gestational age, about 3/4 of samples collected are actually normalized. So this seems to be a really good point at which we start to kind of see the child reaching their normal physiology and their normal maturation of their thymic function. And so we can really get a better assessment of truly what's going on in this child. What we wanted to look at as well, because historically there have been recommendations, we have this serial screening protocol, there have been recommendations for SCID to essentially kind of continue that protocol and do sample collection at weekly or biweekly intervals until the newborn hits 37 weeks corrected gestational age. We saw infants that had anywhere from 1 screen up to 13 screens, and it's anything over 3 to 4 screens that we're really trying to get rid of, because it's just not super appropriate to screen this poor low birth weight or premature infant 13 separate times. And so based on this data, next slide, please. What we are looking as a proposed recommendation is for programs certainly to implement the standard serial screening protocol as suggested by CLSI, their NBS-03 document. There is utility in this, of course, beyond SCID. But with SCID, doing an additional screen once the child reaches 37 weeks corrected gestational age or at discharge, whichever is earliest. And just based on what we're seeing, this should allow for the ability to kind of remove all of the 6, 7, 8, 13 screens, while making sure that we're getting another look at this child at an appropriate time as well. Next slide, please. So we've talked a lot about how many different variations there were for programs. And so certainly I think there is this global need for harmonization in SCID newborn screening. And part of what has arisen out of our work, as well as some work by CLSI, is this new collaboration between multiple stakeholders. So we have representation from CLSI, APHL, the American College of Medical Genetics and Genomics, as well as the immunology community, where we're really trying to assess current practices in reporting results and follow-up results in order to try to make sure that all programs are aware of best practices, and we're providing some guidance on how this should happen. So please stay tuned for that. We are working, we've been working now for maybe a little under a year, but are looking to put some recommendations out shortly on that. Next slide. And, the reason why I think harmonization in this type of work is so important in general, but certainly with SCID, is that we are seeing this really nice global expansion of SCID newborn screening. And so this graph we actually put together from some of our harmonization work, where we have surveyed over 35 countries, I believe, to get a handle on what they're doing. So we can see those in purple are countries that have nationwide universal screening for SCID. Those in orange are currently doing pilot testing for SCID. This may be at the national level or regional level. And then those countries in teal are countries that have universal or routine screening, but more within a regional territory or jurisdiction. So it's really important for us to kind of, especially in the US, to take our lessons learned and to help the global community as they add SCID screening as well, so that we can do it in the best way possible. Next slide, please. So yeah, I think with that, you can see here, these are May Baker and Michael Lasarev from Wisconsin have been really helpful on our project. And then of course the team at APHL, Jalili, Sika, and Cole, all of the newborn screening programs that have helped pull this data and helped us think through this. I saw Erica and Tori on the call. So thank you to everyone. And I think at this point, we are happy to take any questions.
Thank you so much, Ruthanne and Amy. I'm going to go ahead and pull up my slides again. And all right, so now we will go ahead and get into the Q&A. So just a friendly reminder that if you have any questions that you'd like to ask during the Q&A, to please enter your questions in the Q&A box at the bottom of your Zoom screen. All right, so I have a couple just to kind of get us started while people work on getting their questions in the box. All right, so my first question: if a family opts for an in-home birth or a non-traditional birth in a non-hospital setting, is there a way for them to access routine newborn screening?
That's a great question, Emma. So yes, newborn screening programs work closely with midwives. Most midwives are very experienced in collecting dried blood spots and have a process in place for sending them to newborn screening programs. But of course, if there's any reason that a newborn screening could not be completed at home, we strongly encourage parents to visit a hospital or a clinic where the newborn screening test can be done. And that would be within the first few days after birth.
Thank you. All right, next question. Ruthanne, you mentioned in your portion of the presentation that some state screening programs are looking into the addition of a multi-gene SCID panel as an additional step in newborn screening. Can you tell us a little bit about when that takes place in relation to the initial test?
Yeah, I will take this one. And so certainly there is a lot of attention on the potential for next generation sequencing and the incorporation of molecular into newborn screening. And so, understanding that a TREC value gives you a piece of information, but doesn't really tell you as much as we probably want to know in terms of the underlying cause or the true genotypic kind of cause of SCID. There has been the New York State program looked at the potential to incorporate this multi-gene panel into their screening protocol. It was only done as a research study at this point. No state has actually implemented this, but the idea would be that they would do their TREC analysis. They would call that result out and make sure that that child starts getting care right away. But while that was happening, they would use the same dried blood spot. So it would not require another specimen from the baby, they would use that dried blood spot to do the panel, and then provide that supplementary information to the specialist. It's a balance always in terms of cost and what that type of information provides. So I think programs are still kind of looking into the potential utility of it within newborn screening, but definitely an interesting study done by the New York program.
Very cool. My next question. So can newborn screening take place if not in a traditional hospital setting? You mentioned, Ruthanne, that they could go to a clinic or go to a hospital, but if for whatever reason it doesn't take place there, would a family be able to get routine newborn screening at their pediatrician?
Yeah, I think definitely. I mean, I whether or not the pediatrician or family practice provider is set up to collect it, it may differ, but they should certainly ask, and I think it could be set up in another way. So yeah, I think parents should always ask for their newborn screening results, no matter what. And if they aren't available or it feels as though that child did not get screened, absolutely talk to your primary care provider to get that scheduled and get that done.
Thank you. And then our last question for now, if no one else has any to add, can you tell us about any conditions that are on the cusp of being added in the next few years to the recommended universal screening panel?
Yeah, such a big question. And Ruthanne, if I forget any diseases, please let me know. So there have been quite a few diseases that are being reviewed right now for inclusion on the RUSP. So we have Krabbe disease, which is going through the process of review. We have Duchenne muscular dystrophy, which is going through the process of review. There are some states who have started looking at congenital cytomegalovirus. So that's kind of a different take on what we do in terms of it being an infectious disease. There's metachromatic leukodystrophy that has treatment coming. And so I do think that's going to be an ever evolving field for us as there are more and more therapies developed, because it always goes back to what Ruthanne said at the beginning is that need for that effective pre-symptomatic treatment. And so I think as we see more treatments available, we'll start to see more diseases kind of coming down our pipeline. But yeah, those are the ones that I can think of. Ruthanne, am I missing any others?
Not that I can think of, but I'd love to share that. So the advisory committee that's reviewing these disorders, they host, is it quarterly meetings that are open to the public? And I'm happy to send the link to those, but for the folks that are interested in tuning in and just getting a sense of like all the complexities and considerations that go into these recommendations, these are open to the public. And yeah, they're usually about like a day and a half meeting where you can really listen and hear from the states that have either begun pilots or that aren't as far along, and hear about some of those barriers as well.
Wonderful. Well, thank you so much, Ruthanne and Amy. This has been so fascinating, and we're definitely looking forward to hearing more as the paper becomes closer to getting published here in the next couple months. So thank you so much for sharing with us today.
Thank you for having us.
Thank you.
All right, so with Newborn Screening Awareness Month coming up in September, we also want to highlight some of our SCID Compass resources on this topic. On our website, you'll find information on newborn screening, including the history and how your results are interpreted, as well as fact sheets for both parents and providers. We hope you'll remember to take advantage of all of the additional resources IDF has to offer. If your question wasn't addressed during the program, or you have something else that you'd like to ask, go online and submit your question to Ask IDF. Visit www.primaryimmune.org/ask-IDF or give us a call at the 800 number on your screen. Check out the IDF Resource Center and YouTube page to find videos, resources, and more. As we head into fall, IDF has programming for everyone, no matter your connection to PI. Our next IDF webinar will take place on Thursday, September 21st, and will feature an update from Dr. Jude Hajar on her research into PI and the microbiome. And just in time for Newborn Screening Awareness Month, we will host 2 SCID Compass Lunch and Learns covering breastfeeding and CMV, and an update on the ADA SCID gene therapy trials out of UCLA. Be sure to follow us on social media for the latest news and updates. Finally, we hope you will save the date for the 2024 PI conference, which we are thrilled to share will be hosted in person at the Sheridan Grand Riverwalk in Chicago from June 20th to 22nd. We want to thank Chiesi Global Rare Diseases again for their support of the SCID Compass program, and thank you so much to Ruthanne and Amy for sharing these wonderful updates on this important work for the SCID community. Thanks everyone for joining us, and have a wonderful rest of your day.